Thank you, everyone, for joining us today. Leading our discussion is Dr. Paul Chamberlain. He's a board-certified and fellowship-trained ophthalmologist specializing in glaucoma, cataracts, and complex anterior segment disease. Um, Dr. Chamberlain earned his MD at Baylor College of Medicine. He did his residency there, and then he went on to fellowship train at Moran Eye Center under Dr. Ike Ahmed. Now he's based in Idaho's Treasure Valley with his wife and 4 children, and he's combining clinical excellence with a passion for innovation, and that includes integrating home tonometry into his patient care. We're so thrilled to have you today speaking for us, and thank you for letting me welcome Dr. Paul Chamberlain.
Thanks. Thanks for that introduction. I was like, wow, I
You're like, that's
forgot
me.
half of that stuff. And like you said, this really is a discussion, so feel free to interject with questions. You can unmute and ask them, or type them into a chat. If I don't see them, someone can point them out to me. But I think things like this are much better as a discussion rather than a lecture. So give me just a second to start here. And I'm only planning on talking for hopefully 20 to 30 minutes. Try and keep this, short and relatively sweet, and then questions afterward. But I don't want to monopolize everyone's evening. And sorry. Share screen. Okay, can you see my screen now? Sorry.
Yes.
Okay.
Yep.
Perfect.
So yeah, optimizing glaucoma care with home IOP monitoring. I'm at private practice at Intermountain Eye Centers in Boise. We're kind of like the tertiary care center for the area. The nearest centers are Moran, which is about 6 hours away, and OHSU, which is about 8 hours away. So, and then I'm still adjunct professor at University of Utah. And these slides really, a lot of the credit goes to Dr. Barbara Orozco, who's one of my mentors there. She's given this talk a few times and asked if I would, but I borrowed a lot of the information and things from her with some of my own input, experiences, and patient information at the end. Financial disclosures, I am receiving an honorarium from iCare for this talk. So first thing I'd like to start off with, and this can be rhetorical or if you want to share, but really, why are you here? Everyone here has a reason, whether you've heard about iCare Home and wondering how you can fit it into your practice, whether you've had experience with it and want to learn more about it, or how others use it. And I think if you're in this boat, I would like to hear your experiences, because every time I talk with someone who uses iCare, I get a new idea of how I might use it better or differently, because it really is a very new area and we don't have a lot of experience with it. Or you might have patients who are asking if there's a way they can check their own IOPs at home. And that's really how iCare actually got started, was Dr. Orozco and a patient that I met several times when I was a fellow at Moran, kind of said, hey, we want to do this at home, and they started it. Well, they started MyEyes, excuse me, not iCare. They started MyEyes. So glaucoma is a progressive optic neuropathy. IOP is still the only modifiable risk factor. Clinical studies, have demonstrated lowering IOP slows disease progression. And our practice patterns do discuss diurnal IOP, but we really haven't known what to do with this information. And we diagnose, and really all of our treatment is made based on the highest or max IOP, and then trying to decrease it by a percentage of that. But we've known really for a long time that we don't actually identify the max IOP from just from clinic intraocular pressures. Sorry, just a second. Okay, that's better. I have this right thing on my screen. IOP fluctuation, it leads to progression independent of baseline IOP. So a number of, and several of these are post hoc analyses of big trials and things, but that visual field progression, or excuse me, fluctuations in eye pressure do predict, or an independent risk factor for visual field progression in multiple of the other studies, especially SIGITs. Now, one thing to note that is a key difference from what we're talking about now, which is diurnal IOP fluctuation, and what a lot of these studies were studying, was that they were truly looking at, the pressures that they were measuring in clinic, and the amount of fluctuation in those was an independent risk factor. So it is not truly comparing, apples to apples, so to speak, in terms of fluctuation, because what we're measuring with iCare Home is diurnal fluctuation. But we do know that fluctuation is not good for glaucoma. So there's an argument that isolated, in-office IOP is no longer sufficient. We know that, positioning, time of day, cortisol levels, nitric oxide can, uh, contribute to the fluctuations. And we're really, our model that we've done for, decades is really just we measure IOP over a few seconds over an entire year. And if you calculate it out, it's about 31 million seconds in a year, and we're checking the IOP in about 15 of those, and we're making most of our clinical decisions based on those very few measurements. And we have all had the normal tension glaucoma patients, or even patients who seem more like POAG, but they never have really elevated pressures in clinic. So, we have glucose monitors for diabetes, we have blood pressures for hypertension. What if we had something for high pressure as well? And then another thing, not all glaucoma treatments are truly equally effective in terms of the effect on diurnal IOP. PGAs and CAIs are more effective during sleep for most patients. Brimonidine and timolol are less effective at lowering the pressure at night. And SLT, MIGS, and more traditional glaucoma surgeries are better at kind of leveling off the amount of fluctuation. So really, and this kind of goes into another subject that I'm not truly trying to broach today, but interventional glaucoma, can we really kind of determine what therapies we might want to do for patients prior to visual field loss, earlier in the disease, and with less invasive things to try and preserve even more visual field rather than waiting for people to lose vision in order to do something. So in general, the iCare, not just iCare Home, but iCare, or rebound tonometry, has really been very well validated. It is not always, well, it's a good approximation to Goldman applanation. It's not always exactly the same, but I think the most important thing about iCare in general is that it's internally consistent. And honestly, when you're having your technicians check pressures, or even you, and as a glaucoma specialist, I try not to do it, but I think we all probably have at some point. You kind of want a certain pressure, and with applanation, you can always adjust things a little bit. And so sometimes iCare, I think, is actually a little bit more objective, but definitely it is a very well reliable and reproducible device. And iCare Home is something that can be easily used by patients in their home with minimal training. It is FDA cleared for home use if the patient has a prescription. So they can't just order it themselves, but with a prescription, they can rent it or they can buy it. And it doesn't require anesthetics, and it uploads the information very easily. This is something, I'll kind of jump over this, but in general, studies have really demonstrated higher IOP early in the morning. This kind of highlighted portion there, the maximum daily IOP occurred outside of clinic hours between 4:30 and 8 a.m. on 24% of days, and mean daily maximum exceeded the clinic maximum in 45% of patients. I would say, at least in my subset of patients that I've done iCare Home on, almost probably 80% of them, their maximum IOPs that we find are not within clinic hours. And younger age, male gender, in absence of prior filtering surgery, are more likely to have significant spikes in their eye pressure. So the value of this for me, I think of it in two regards. One is as a diagnostic tool. The question is, should I, or really how should I intervene? So it helps me identify the IOPs outside of clinic hours. And then I can a little bit more manage and identify more personalized therapy because not everyone responds the same. And surgical inter we can hopefully do surgical interventions or less invasive surgical interventions earlier when they might work better, to try and prevent them from needing, larger interventions. And then also as a monitoring tool. So if you've done something already, whether it's SLT, some sort of MIGS procedure, now, Durista or iDose, can you catch when the effects of those are wearing off earlier so that if you need to, redose them or redo them, that you can do it before the IOP comes up significantly. I will note some of these things are theoretical. I have not yet actually done any, Durista or iDose, putting in because I saw iCare going up. Some of these things are not things that I necessarily have done, but they are ideas that I've heard or that I think are reasonable. So just how many of you, well, I don't know if there's a way to raise hands on here, so I'll leave this rhetorical, but I'm just going to kind of go through when you prescribe an eye care home, how the information is then sent to you. If you've never seen these before, maybe you have, but so if this is a little bit basic, I apologize in advance. And at the end of this, if you're interested, I'll actually just hop on to show you how to prescribe it because it's actually very simple. And I think there are a lot of, it's good to just kind of see how it's done. But so the information is presented. This is one of the printouts that, or and for me, it's a printout because I'm on paper charts, but one of the things that will be sent to you as the prescribing provider. So this is for a single eye and a few things. It'll give you the highest, the lowest, the mean, the standard deviation of all the measurements. And then this chart in particular is actually each one of those kind of columns is spans 3 hours. So it's the average pressure that um, for the entire week in those hours. And then down here, and this page actually goes on for a long time. It actually has every single individual measurement just in a list and what time they took it. So what I consider significant, because that's the other question, is okay, so we have this data, which is a lot of data that we don't always honestly know what to do with. So what should I consider significant? And I consider if there is a fluctuation of 8 to 10 or more between the lowest one of these averages and the highest, that's a pretty significant fluctuation. Or if the standard deviation is greater than 3. The next thing, and so you would have one of these pictures that's on the left for both the left eye and the right. And then you can also get this one on the right-hand side of the screen now that has both eyes on the same graph. And this one doesn't actually have averages for each of those time points. Each one of these bars in here is actually a full day and it has all the measurements. So this is all the measurements that the patient took, throughout the week. And you really can, it's a nice visual because you can see these very consistent, early morning spikes in pressure. And one eye is oftentimes, if you have one eye that's progressing and the other eye isn't, you will see this where one eye is spiking, even if their clinic pressures are the same each day. So I'll go over some case examples, and some of these are mine, and some of them are from Dr. Orozco or her colleagues, but they were all very good ones. So I included some of hers. The first one is a case of, was SLT effective? So a 76-year-old white female with pseudo-X in the left eye, which really means probably both eyes, but a normal IOP in clinic, pressures are 16 to 18. OCT shows a little bit of thinning, visual fields are normal, but got an iCare home. And really that left eye is definitely higher. And not just, and it's really the baseline is a little bit higher, but especially the early morning spikes are higher. So they did SLT and it really leveled out. I don't actually know, I think this is about a year later, or 6 months later is the second graph there, but there was a significant decrease and both eyes are much similar. So and I'm going to come back to SLT because I think there's a lot of usefulness with SLT, but we'll come back to that at the end a little bit. So number 2, angle surgery effectiveness or MIGS procedures. 37-year-old with uveitic glaucoma who's complaining of intermittent headaches, but in office his pressure is always in the teens, maybe low 20s. Home monitoring has fluctuations up to in the 40s, and undergoes a GAT. And this graph is actually different. I'm not actually sure how they got this, but the top graph is the right eye, bottom is the left, and the blue and the red are the pre-surgery, and the green is the post-surgery. So, I mean, there's definitely a significant drop altogether, but also importantly, there's a significant reduction in the amount of fluctuations. Number three, this is, I think the example here is that sometimes, you know, we can, we it's nice to have things that can be comforting to patients, especially who've had complex problems in the past or that had significant problems that happen quickly that you wouldn't normally catch, if you're just doing routine follow-up. So this is an 84-year-old cardiologist, had pseudoexfoliation syndrome, maybe, glaucoma, had cataract surgery in the right eye, and really it was post-operatively. Hadn't had much problem with pressure before, but had IOP spikes to the 50s post-op. Whether this was from the pseudox or a steroid responder, there's some concern about whether there was a herpetic uveitic component, but developed PBK essentially, thought to be due to the extremely high pressures and decompensation. It ended up kind of count fingers vision, even after surgery. So now the time has come. Vision's getting worse in the left eye. Pressure's 14. He's on a PGA and COSOPT. Cup to disc is 0.6. Visual field, sorry, I don't actually have the visual fields, but they weren't horrible. But just worried, could the same thing happen again? And so elects to undergo a canaloplasty with a hydrus. This is back when you could do both of those procedures together. And he actually had the device. So lots of times we'll do a pre and post, but he had the device, throughout the first week of surgery to kind of catch to see if, in case there was a big spike. And you can see with the canaloplasty hydrus, his pressure dropped and it just stayed flat. Great response, but it kind of gives peace of mind both to the doctor and to the patient, and can monitor, if he noticed it coming up, he could get into clinic sooner, to try and prevent what happened to the right eye from happening to the left. This is TRAB versus MIGS versus observation. This is a case of mine recently, and this is honestly probably one of the biggest reasons why I personally use iCare Home. So I had a 65-year-old, no reported history of glaucoma. Initially, when he presented, this was presented to the outside provider, had uncomplicated cataract surgery in November of last year. Postoperatively had IOP spikes to the 60s. Thought to be steroid response. There was no history or mention of pseudoexfoliation. And was started on medical therapy. IOP down to the mid-teens by December. So really just a few weeks of these really high pressures. This was his initial visual field in December. And then he was in January, they referred him to me. I did a repeat visual field, and this is the same right eye. And he's 20/25, but he can feel the constriction. He knows that his vision's getting worse. Now, I don't think that there's actually this much different in the visual field test. If you look at the false positives on that first one, it's about 56%. So I think that visual field was actually better than it probably was. But definitely with his symptoms, there's still concern for progression, even though his pressures, are much better than they were right after the surgery. So I see him basically when I get the second visual field test. He does have pseudoexfoliation kind of material on the iris, so I do think this is pseudoexfoliation, and it's probably been going on for some time, maybe even with occasional spikes. But he actually opted to buy an iCare Home, and I have 3 patients who have bought one. They're all engineers, and I think in the right patient's hands, it can be a good thing. I definitely do not think buying an iCare is for the vast majority of patients, but in this patient, it turned out to be a really good thing actually. So his and you'll notice this is like January to April. This is a ton of data here, but I'll kind of start on the left-hand side. So this is January, these first 2 or 3 bars. And, in clinic, we were measuring pressures between about 12 to 16, but he is still spiking up to the mid-20s, almost to 30 a lot of the time. So with how rapid he progressed, I decided to do a trabeculectomy. You can see, here where we did the trab, and he had this heme kind of at the flap interface right after the trabeculectomy. There wasn't a whole lot of flow, but I don't like to cut the sutures too early. So about 2 weeks after we did that, the initial trab, pressure hadn't come down much. So I cut the sutures, and there was still heme there. And we were massaging. Pressures were down a little bit, really only spiking to 15 now, but still in clinic pressures were not much different. And then around week 4, that heme just dissolves and his pressure just dropped. I mean, it's beautiful. Pressures are 5 to 10. He's doing very, very well. But it kind of, having the eye care home throughout this process helped kind of the decisions and how worried we needed to be or aggressive with things, in terms of the management, and also hypotony. So I told him, when we cut the sutures, and especially, I was like, okay, we're still doing the massages because we're not noticing it. But if you notice your pressure goes down to 5, quit doing the massages. I don't want you to become hypotenuse, or to get choroidals or something like that. So it has been a very good thing for him in this case. And then the last one, and sorry, I don't have all the patient information on here, but should we observe or not? So this was a patient who was referred to me. She's in her 90s, or maybe late 80s, but she has slow progression of her glaucoma. Over the past couple of years, pressure in the clinic is always right around 10, and the question is really, do we need to do something or not? In a patient like that, who's that old without slow progression, I usually would not do a trabeculectomy. But if they had significant, pressure spikes, I might consider an eye stent or a canaloplasty goniotomy, something less invasive. In her case, her pressure, I mean, the other thing to know about these is they are auto scaled. So it'll almost always look like there's a big, spike in the morning. But look at the scale here. The difference is between 7 and 9.5. So there is really very, very, very minimal fluctuation, with her pressures. And I kind of said, look, I probably wouldn't do anything for you right now. This is slowly enough. And so it really helped us to not do something. So in summary, the iCare Home is nice for the ability to detect IOP spikes and fluctuation with IOP variability. It can detect real-world responses, to medications as well as therapy. And it can really be eye-opening sometimes when you see how high the pressure goes in these mornings. And then reduced patient anxiety or visibility, for medication effectiveness. They might be more compliant, more adherent, or they just kind of trust that what they're doing is working. Now, I'm going to come back to this slide in just a second, in both of these. I will touch on this for a second. So, how will this change my management? That's the other big question that I think is always important to consider. It's nice to have this data, but sometimes if I didn't have it, would it really change what I do? And in all honesty, a lot of the time it wouldn't. So although I think on the whole, I prescribe eye care at home a lot more than most people. In the past 2 years since I've been out of fellowship, I've only prescribed it to 30 patients. So it's like a patient a month, that I'm doing this for. It is, and I'm seeing, 30 to 40 glaucoma patients a day. So it is not like all my glaucoma patients are doing this. It is really when I have a question, or a management, decision to make, and I think that the information is going to help us, make that decision. So when do I personally use it? The first is someone who's progressing at a low pressure. If someone, their pressure is 10 to 15 and they're progressing, um, if I see high spikes, I'm probably more likely to do a minimally invasive procedure, thinking that, hey, maybe if we can just reduce the spikes, we can slow the progression. Whereas if there aren't many fluctuations and they're progressing at those pressures, really they probably need more of a traditional filtering surgery, like a trabeculectomy. And if you're not a glaucoma specialist, you could still, and you weren't be doing these things, you could still have this information to send to your glaucoma specialist, when you refer them. And then the second is when I'm doing SLT on a patient where their pressures in the mid to low teens. Usually, I'm not expecting, and I try and prep all my patients for this. I am not expecting a big drop in their pressure. When I do SLT on someone whose pressure is 14, I'm not truly expecting a pressure of 10. In residency, I always just told patients, hey, we're trying to blunt fluctuations. We know that they happen. We know that SLT can do it. We're not going to see a difference in clinic, but we're just treating this, hoping that it is blunting fluctuations. But now we could actually see that. You could get the iCare home, a week before, or sometime where they do it for a week before, and then 6 to 8 weeks after the SLT, you can do it again and really see, hey, is there a decrease in fluctuations? And if there's not, maybe you don't wait 6 months or a year to do something else. You just say, hey, this really didn't work. We should move on to something else. Um, so I'm going to go back here. So just a little bit about how to prescribe it, the nuts and bolts. It's very, very easy. I'll show you in just a second. But important to know, the prescription must be in before the patient can rent. So I tell my patients, hey, we're going to send in this prescription. I give them something that they can log online to order it. But when you do the prescription, they'll actually be contacted by MyEyes as well. So you don't have to. It only takes 2 minutes to prescribe. Extremely easy. When I have a new technician who hasn't done it before, I'm like, hey, we need to prescribe iCare Home, and they say, how do I do that? I give them the website and say, see if you can figure it out. And if you can't, come get me. And they always figure it out. It is very, very straightforward. The cost to the patient, it's about $250 a week. Now, I'm not going to speak too much to this. There is probably going to be some sort of um, uh, program or deal, so to speak, where it's essentially a 2-week rental, but it's only, I think, around $350. Don't quote me on that. But so you can have it a week before and, at any point after, for anything where you wanted to compare before and after treatment. And then most importantly, and dealing with all the prior authorizations for medications and things, this is huge. MyEyes does all the work. So they explain and educate patients. If actually, I can't ever remember getting a call from one of my patients asking, hey, how do I use this device? But if we did, I would say contact MyEyes and they take care of it. They provide great support to patients. They've got videos. They have people who can FaceTime with them to show them things, or just talk them through it. I've had patients where they got it and they were just like, I can't figure out how to use it, or I can't do it, and they've refunded those for them. And then this one is also really nice. Most of my patients, I tell, hey, you've got to pay out of pocket for it. They might be able to, you might be able to get your insurance, but that's not something our office does. You can work with the company if you want to try and do it. So I very upfront say, you're going to have to pay for this out of pocket. And if you want to try and do it through your insurance, it's not through us. And I have never had to deal with a prior authorization or anything for any of my patients who've had it. Now, most of them end up just paying out of pocket, but I have had some who get reimbursed from their insurance after working with MyEyes. And then you get the results sent to you, and are summarized very nicely. So this is the website, and I'm going to change the screens here for just a second. So can you see the screen now, the myeyes.net?
No.
No?
The
Okay, just a second. What about now?
Yes.
Okay. So this is where you go. Um, I'm going to go first time prescribers. You can go here, and basically they just want some information about you and your practice. It's just a one-time thing you set up, basically, that you're in their system. But for submitting the RX after that first time, you just click this button. And if you click that first, you could say I'm a new. But for returning providers, I just put in my NPI number or your email. 5, 6. And it has your information automatically, so you don't have to. It's connected to an account with you, so it will be sent the same way to you each time. So you just fill in all the boxes. The diagnosis code, you put whichever one it is. Purchase, I usually do rental, but then you click this, oh yeah, 1 week, and you click this button, yes, I authorize the prescription to be expanded to cover a purchase if the patient desires. So sometimes patients will be like, hey, I wanna buy it, and they can. Now, if you just left this as a purchase, MyEyes will actually contact them. And if the patient just wants to rent it, they'll rent it. So it's not even that big a deal if you just do that. And then you just put the patient's information. So first and last name, date of birth, email, phone number. It's not part of a study. And then submit. And that's it. You're done. And you don't have to do anything else, which is very, very nice. And then to my patients, I will go back to this. My patients, I give them the sheet, that just has information on it, and I'll give it to them and say, hey, here's the website. Go on, 24 hours from now, and you can order it online. So I'd just like to thank my patients, and then a lot of my colleagues and collaborators, especially those at Chamberlain Eye Center. And this is my cell phone number and email. Feel free to reach out anytime if you have questions or concerns or ideas. So I'll stop there. Does anyone have any questions? Let me ask, has anyone here used it, very, very often? Is that Dr. Albert or Herbert? Sorry.
And I'm not a doctor. I was just hired by MyEyes, literally started this week, but
Oh,
I've used it
okay.
twice. Yeah, I've
Okay.
used it twice, and I just found it to be very informative. I really like to be involved, in my own health journey with this condition. And I thought it was really fun to use it. It was very easy. I was so impressed with MyEyes that I contacted them about possibly working with the company, and here I am. So
Cool.
yeah. And I really appreciate your perspective on how you as a doctor would use it as well. So this has been really helpful for me just to gain more information.
Thanks.
Hello, can you hear me?
Yes.
Okay, I missed the beginning part of it. I don't know if you had addressed these issues. I hope it's not a duplication. How do you get the result? Is that coming to you through your registered email and you get alert, or you have to log into the portal to look for it?
Yeah. So I sorry, I didn't actually go over that. So you can well, I get mine through email. So they send me a secure email, and we download it. And I'm on paper chart, so we print it off. You could get it into your EMR if you wanted to. I think if you're on an Epic system, they're working on having something where it automatically uploads into Epic, but don't quote me on that. So there's some flexibility in how you get it, but I get it as an email, and I um I print it off, review it. But so when I order the other thing, when I order it, I usually will set an appointment because it'll take a couple weeks for the patient to get it. And then, well, the results are pretty much automatic. But usually I'll set up a follow-up appointment about 6 weeks after I see them where we sign them up. And really I review it with them at that point. So oftentimes they'll come in and I pull it up on my phone and just like, oh yeah, here it is. And we review it at that time, and then I print it off and put it in their chart.
Is
But yeah, I get it emailed.
is the result coming to you daily, or it coming to you at
No,
the
no, no,
end
no,
of
no,
the
no. No, you just get the summary after the week is done. So I'll get an email that just says, well, I get an email first that says, hey, your patient rented MyEyes home. And then, a week and a half later, I'll get an email that says, hey, here are the results for this patient. And it's just a PDF document with the summary, those summary pages, one for each eye, and then the two eyes on top of each other. And then if you want, you can get all the individual data points as well.
Hi,
But I do not log into a portal or anything like that. Now, for patients who buy their own, it's actually a little bit different. So they have access to that. Nothing comes to you. So if they purchased it, the only way for you to get the data is if the patient looks at their portal or prints it off. So usually I will they will bring in, the week summary that we want or something like that. And they have a portal. But I'm not monitoring, for the patients who purchase it, I'm not going in there and monitoring anything, which it could be a lot of work. And that's, I think, I think there are a few things that would really make this kind of get a lot bigger, or I guess more mainstream. One would be, hopefully eventually insurance will reimburse, patients for it, and also reimburse physicians. There's no CPT code. You can't bill for interpreting this or anything like that. And hopefully in the future, that could change. Just like a cardiologist, reviews the Holter monitor, there could be something where we can review, the IOP data. Currently, there's not anything like that, but I hope that in the future there could be. Um, what was I going with that? I also think really we need to. It's so much data sometimes. Sometimes you don't know what to do with it. And I think over the next 10 years, there will be more kind of research looking at this, and what, especially with, AI and just larger amounts of data, how do we use this data? Because sometimes it doesn't always answer the question, to be honest. Sometimes you're kind of like, we've got this. Now what do we do? Um, but I think it's useful. And I would not recommend doing this for, all your patients. But when you have someone where you're kind of on the fence, do we need to do something? Do we not? I think it can help you make a decision, or help a patient be okay with the decision that you think they need. If you think, hey, we should do SLT or we should do surgery, and they're kind of on the fence, because they're progressing, but their pressures aren't any worse and they're not noticing it yet, but you can see it. If you get this and their pressure is going up, significantly. I've got another patient who her pressure's, going up into the 30s or 40s, and I've been trying to convince her to do a trab for a while, even without that. But just because her visual fields were getting worse, and now she's kind of like, okay, yeah, we should do it. So it can be really useful, but it's not always that black and white.
I wanted to jump in real quick about the insurance because it is such a big part of our service. And it's a question that always comes up on the doctor side and the patient side, I would say. It's a hot topic, if you will. But insurance has been covering more and more either the rental or the purchase. So with United, we are a preferred vendor. And then we have a lot of other insurance companies that we work with. So when the patient does rent or purchase from us, we provide them with all the tools to submit for that reimbursement. The patient also, if they want to get more information as far as what they're looking at before they move forward, they can call their insurance company and ask if they have any DME coverage, and then they'll have a good idea of what they would be looking at. And then if they need any more help from what all the things we provide them with as far as submitting, they can always call us and we'll help them with that. But we are seeing a lot more insurance coverage with the patients.
And I think that's changed even over the past year or two,
Yeah.
because 2 years ago you
Yep.
never got covered. But I've definitely had patients in the past few months who's like, oh yeah, my insurance paid for that. So
yep, it's
I
exciting.
think they're getting better.
Yeah.
So what time should the patient take their pressures? Do you have them take their
Yes.
pressures
Oh,
first thing in the morning before they get out of bed, lying down? What do you do?
so yes, sorry, I forgot to. So I tell my patients, just to make it easy, I say first thing when you get up. Now, if I ask them what time they wake up, I say, what time do you get up in the morning? If they get up at like 9 or 10, I'll ask them to wake up at 6. If they're waking up at 6 or 7, I don't tell them to wake up early, but I say, wake up and check your pressure every 3 hours until you go to bed. Just because that's easy for them to remember. I don't do positioning. That's a good idea. I don't actually do, supine or upright positioning. I just say, hey, right when you wake up, check your pressure, and do it every 3 hours until you go to bed at night, ending right before bed. So I used to try like, oh, do it at this time and this time, but it just got confusing. So if I say from this time, Q3, it's tended to be a little bit more straightforward for the patients.
Okay.
Does anyone else yeah. Is there anyone else who's used it who does a different kind of schedule in terms of asking patients to check it?
Um, uh, I'll say, so I do work for MyEyes, and I have ice syndrome, and like we were trying to figure out what is the next shunt for me to have, and one of my specialists mentioned getting the home tonometer, which I didn't even know what that was, and so I rented it, and my pressure was spiking into the 40s, and we didn't know that. So what we thought we had a few months to figure out, we had to do a different surgery, a different implant sooner. And I just think it's invaluable to know for patients that are not stable, like it's invaluable to know the your IOP on a daily basis. You can take it whenever.
So I use it and have used it for a while. Actually, I use the iCare Home 1. Not as easy to use, kind of glitchy. iCare Home 2 is much better. I do what I kind of asked about. I tell the patient the most important thing I need is your pressures lying down first thing in the morning before you get up. And that is almost consistently the highest pressures across the course of the day. I just had a patient a couple of months ago whose pressure spiked in mid-morning, like 10 o'clock. And I started delving into, okay, what time do you go to bed? What's going on here? She goes to bed at like 9 o'clock, gets up at 3. So the whole thing about it being the highest early in the morning when you're laying down, not for her. But she didn't have the sleep pattern that most patients have either.
Yeah.
So that was interesting.
That's really interesting. You know, I haven't done that, but I mean, again, that's why I wanted to hear from other people, because I haven't done supine testing. Does the iCare Home 2, I know like the iCare, there's only one of the models that is actually approved for supine. You can use the iCare Home 2 supine. Is that?
Yes, iCare Home 2 can be done
Okay.
supine, and that's
Okay.
biggest advantage. One, it's easier to use, but that's the biggest advantage. The one you can use, the iCare, not home, but regular iCare you can use supine or whatever position, is the IC200. I
Right,
actually
okay.
never use that. I don't really use it much in clinic. We've got 2 or 3 of those around, but I don't use it. I use the iCare Home to get the patient in their environment, especially early in the morning, laying down. I want to know what that pressure is. The first time I ever used it, when I first used an iCare Home 1, I had a patient who was just starting to progress in their visual fields and on their OCT and things like that. Pressures were in the low 20s, couldn't get the pressures down any further. We're like, that's funny. Maybe these low 20s, or we thought those low 20s were causing the problem. Then we did iCare Home 1 in the manner I described. Her pressures in the early morning lying down were 40 consistently all the way across the week, every single time.
So if you see fluctuations like that, and this is a question I've asked, because I've gone back and forth, and I actually have recently changed what I did. I used to, and this was, I guess, more for low pressure glaucoma, but if I had someone who was progressing around 12 to 14 or less, and they're having, spikes up into the 20s or 30s, would you do a MIGS procedure in that case, or would you go more to a filtering surgery?
I'm an OD. We have
Okay,
SLT. We have ophthalmologists on our staff part-time. We have SLT there in the clinic. We've done Durista. We've done iDose. We've done all of that kind of stuff. But unlike that case I just told you about, that one we tried SLT. Then we had the ophthalmologist turn up the power a little bit, tried it again. Did not match those
do
pressures.
anything.
Didn't. Referred out to a glaucoma specialist who did. What did he do? It didn't work. Can't remember if it was a trab or a tube.
Okay.
I think she went on to a tube, and I lost
Okay.
track of when happened.
Yeah.
So
No,
nothing
it's
worked.
yeah. No, it's like we have a whole new side of the disease that we've never seen before, but we don't really have studies that have shown, what we need is really a recreation of all the major glaucoma studies, but looking at fluctuation in IOP instead of just, baseline IOP, like, clinic, but anyway, that's neither here nor there. What was I going to say? There was something else that you had said that, oh, another important thing, just if you haven't seen the iCare home, and just so you know, your patients will find out, but you might get a phone call or is unlike the eye care that you use in clinic, the device itself does not display a pressure. So the only way for the patients to see, they're going to check the pressure, but it just records it online. It uploads it automatically. But if they want to see what their pressures are, it's not like they're going to do it and look and be like, oh, my pressure was 13 right now. They've got to go online to see what those pressures are. So that's just a little bit different, and it's fine. Honestly, I think it's good because, but it was done definitely for a reason. But it is different than the ones you do in clinic. And if you have a patient that calls and asks, they can see it. They just have to go online when they check it. Okay. Any other questions? Well, thanks for coming this evening. Feel free to reach out to me if you have questions. You can email or text or call me, whatever is convenient. So thanks for having me today.
Thank you, everybody. I also put my information up there. So if we'd love to do like lunch and learns virtually, would love to work with any of you as far as helping your patients with rental or purchasing. So let me know if we can have a quick meeting. I would love that. Did you have anything else, Erica? Okay. Oh, there's Dr. Rowe. You're on mute.
Sorry, I'm late.
Hi, Dr.
Erica,
Rowe.
sorry, I'm not sure who. Ashley, do you know when the pricing will be finalized for that compare where you can get it for 2 weeks? Is that,
Soon.
that's in the works right now?
Very soon. Yeah, we're working on kind of focusing on the patients that want to get a baseline before they're changing medication, before they're getting SLT or they're having a procedure. And then, like you said, Dr. Chamberlain, about 6 to 8 weeks later, we would send the device to them again. And then the doctor would be able to compare where they were at and then how effective the treatment was and whether they are good or if they need to move on to something else. So we
Okay.
just heard from a lot of your colleagues that that's something that they want. So we put that together, which is exciting. So we should be rolling that out soon with the pricing and how all of that will work for everyone. But yeah, we're excited.
Thanks.
Yep, and please reach out if you have any questions or need anything. We're happy to help in any way we can.
And Dr. Rowe, sorry, I think you were about to say something and I cut you off.
Oh no, I'm sorry I missed your excellent meeting. I was stuck in clinic. So
no.
California time zone.
yeah, well,
Love to too.
would love to maybe, I mean, if you're open to it, would love to
I
communicate
can hang on now
privately.
for a little bit longer, and yeah, I can go through it again or talk.
Oh,
Yeah, whatever's best for you.
well, I appreciate it. I mean, I spoke with Barbara as well in the past, and I just, home tonometry is so brand new to me, and I'm just now starting to prescribe it, and I'm kind of utilizing it quite a bit for almost my non-conventional uses, such as folks that are not ambulatory who can't come in, etc. But are you using it more for determining surgical candidates and SLTs and that sort of thing?
I think for me, the biggest use is for low pressure glaucoma.
Yeah.
Trying to decide, if someone's progressing at a pressure between, 10 or 9 to 14, do we just observe? Like if there aren't many fluctuations and it's a slow progression and there's not much fluctuation, I'm probably going to be more likely just to say, hey, let's just watch this. Especially if they're elderly. If they're younger, I might still try something. But if they're, in their 80s or 90s, I'd probably be like, let's, we don't have to do something right now.
Yeah.
If they're spiking, quite a bit, then usually I'm talking about surgery with those patients. And the question, I actually, 6 months ago, I would do a trab, and then I've been talking with some people who said, hey, well, if they're having fluctuations, maybe just a MIGS procedure will blunt those spikes enough, and it's less invasive. So that's actually what I'm leaning towards now. Is if I have someone progressing at a low pressure, I'll do, try a goniotomy or an eye stent or something like that, and then if that
Mhm.
doesn't work, move on to a trab. But so
Are
those are the patients that I'm doing it mostly right now.
you able to convince your patients to do the pressures 3 or 4 times at home, or what sort of regimen are you pretty happy with?
Yeah, yeah. So I tell patients really, hey, do it. Well, I ask them when they wake up. If they're waking up at 10 o'clock, then I'm going to ask them to wake up at 6 for a pressure, then they can go back to sleep. But assuming, a lot of my patients are waking up at 6 or 7, I say, first thing right when you wake up, check your pressure, and then every 3 hours throughout the day, until
Sure.
you go to bed at night. And really most of them do a pretty good job.
Mhm.
I have some patients who've tried it and they're just like, I can't do this, and they, we don't get anything. But most of the patients are able to do that pretty well.
Yeah.
Um,
Yeah.
yeah.
Well, that's great.
What do you do? How often do you have
Well,
them check it?
I'm just starting actually. However, the few patients that I have signed up ended up wanting to purchase the device versus the prescription rental. Are most of your patients in the rental program or in the purchasing category?
Most most are in the rental, which I think is good. I think for the right patient, someone who has significant fluctuations or bad disease and is like an engineer, I think are the patients who are good for purchasing because they'll be able to like look at the data, and really kind of understand it. Now, I would say purchasing is not for the faint of heart. I definitely those I have 3 patients and now 4 who've purchased it. And they'll, periodically, I mean, not uncommon, I get text, hey, my pressure's doing this. So you're kind of like, and I for my advanced patients, oftentimes they have my phone number, especially if I've done surgery on them. So
Yeah.
I'll get texts or hey, my pressure's doing this, and we'll make changes,
Uh,
from that. But if you had all your patients with a purchased eye care home, you could just spend all day doing stuff like that. So I would be hesitant to, have lots of patients who purchase it just
hmm.
because the amount of work you're going to have to do, and sometimes you don't really know what to do. Like, they're
Yeah.
because in some ways it was, in the past, I almost feel like we have blinders taken off of us now. And it's exciting, but it's also like it was nice when you just had 4 pressures a year and you were making your decisions off of those pressures and you knew it. Now we have all this new information, but you
Yeah.
don't always know what to do with it.
Yeah.
And for the patients who are purchasing it, I mean, it's just exponentially more. A week is kind of you have it's this nice tidy little package and you can say, okay, this is what's going on. When they're just doing it all the time, there's like no limit. So
Yeah. Yeah. You want to be
yeah.
careful about sharing your number. Yeah.
So
Well, I appreciate that.
yeah.
Yeah, I mean, for me, I mean, a lot of my patients, I mean, just case in point today, I did an SLT on a patient where the pressure was still in the upper 20s, 4 weeks out. And then I brought her back. I convinced her, hey, let's wait a little bit and come back. And lo and behold, her pressures were like in the teens. So just another case of a patient that where the pressure dropped after enough time. However, I'm not 100% convinced that she's not spiking sometime, during the night or whatever. So I can see a place where this might be helpful. She doesn't have the home too, but I was wondering if you see a use there.
Yeah, no, I think post SLT. So that was the low pressure is one. The other area which I haven't done as much of, but I think especially with their new kind of compare thing, I will do more of, is especially in patients where their pressure is not, we're doing SLT and their pressure isn't in the 20s, but it's maybe in the teens, and you might not see a big drop in the pressure, but you're still hoping that you're going to reduce fluctuations. That if they're on latanoprost and Cosopt and you do SLT and their pressure hasn't changed, but you can see a reduction in their spikes, you can still say, hey, this was still effective. I know our clinic pressure isn't any better, but we've definitely reduced fluctuations. We don't need to move on to a new therapy because we did do something here. And I think that is a huge area that I will be doing it more in. But I haven't had a lot of patients who want to do it twice, especially, with the 250, just pay for it again, because they'll ask me like, well, how's it going to change what we're doing? But I think if we can just upfront say, hey, we're going to do this a before and after, more patients will be willing to do that. So
Yeah. No, I mean, I think home tonometry, home biometrics is just very exciting. I think there's a lot we don't know what to do with yet, but
yeah.
I think to be able to correlate it with, in the future with visual field and, other metrics that we typically follow, and see if the max min and the amplitudes correlate well with that would be very, very interesting.
Yeah, I agree.
Well, thank you.
No, thank you.
Sorry to keep
Yeah.
you over time, but
Oh no, this
I'm sorry I
this
missed
was
your
fine.
meeting.
I feel like the less I talk, the better. So no, I love the input here and what other people are doing. So
Yeah. I mean, how are you manually? I mean, how are you? I mean, I know Clinic has a really nice graph that you're able to pull. Are you typically downloading it and just pasting it into your EHR, or how are you able to put it into your workflow?
we're on paper charts still. So we print it
Okay.
off and put it in our, it's right next to the
Well,
visual field. It's just in the chart with everything else.
lucky you. Oh man. Yeah.
Oh, right. We said he's
Yeah,
bragging
you
with
can
all
see
his
me.
charts
You can see.
behind
I don't know
him.
if you can see behind me. I've got a wall of charts behind me right here. So
That's beautiful. I mean, you figure out a way to stay paper. That's,
Yeah.
goes to you, man. Yeah. So,
Um,
anyways, thank you.
yeah,
Thank you so much, everybody, for attending today. Thank you, Dr. Chamberlain, for your time. I know it did take a lot of time to prepare and give this talk, so we appreciate it so much.
no problem. My pleasure. Good luck.
If anyone needs anything, please reach out.
Thank you.
Okay.
Good
Have a great
night.
night. Bye.
Bye-bye.
Bye.